We are live now, doctor.
Yes, yeah. Hello, very good evening to everyone here, and welcome to the first webinar in our series of MOS clinical rounds. So, this is going to be a very special kind of series. So, these are daily case scenarios which are not usually discussed in conferences because in conferences we have bigger issues. Here, these are the small, routinely seen cases that we are going to discuss. Like today, we have two very common clinical scenarios. One is conjunctivitis and is VKC. So these are some things which we see on a daily basis, but all of us have a different way of treating them. So today we have an excellent panel of corneal surgeons and a great moderator with corneal surgeons as case presenters too. So all of them together are going to dissect out these two conditions, and we are going to discuss on what are the various ways, what are the ideal ways of treating, and how we go about it in a most scientific manner. So we have our moderator here with us, Dr. Sangeeta Wagh. She is driving also right now. Yes. So a very warm welcome to you, Dr. Sangeeta, and to all our panelists and to the two speakers also today, who are also part of the MOS Leadership Development Program. So, Dr. Sangeeta, over to you. She is one of the most brilliant cornea surgeons from Pune, very senior, very academic oriented, and she would be one of the the best persons who would be a good moderator for today's discussion. Over to you, Dr. Sangeeta.
Thank you so much, Anaga, for actually structuring such a beautiful program, which is going to help all of us in our day-to-day practice.
Dr. Sangeeta, your voice is not coming clearly. Maybe because of
she's lost the signal.
Driving.
yeah. Doesn't matter. I think what she wanted to say is yes, we have a very good lineup of panelists also. So we'd like to introduce the panelists here. Dr. Vinay Agarwal, sir, he is from Bombay. Again, a very brilliant academician and a great surgeon. Very warm welcome to you, Dr. Vinay. Dr. Ajay Kulkarni is a very senior cornea surgeon, very brilliant surgeon from Nagpur. Very warm welcome to you. And Dr. Rohit Bang, he is from Aurangabad. Very warm welcome to you. Again, a very brilliant corneal surgeon. And we have our two cornea presenters here, Dr. Rasika Thakur from Mumbai and Dr. Shraddha Nawandar. So, Dr. Rasika would be speaking to us and she would be presenting a case on conjunctivitis and Dr. Shraddha on VKC. So, very warm welcome to both of you too.
Thank you.
So, I'd like to now request Dr. Rasika, you can please start your presentation on conjunctivitis.
Yes.
Yeah, you can start sharing. Yes, you can make it full screen, please.
Yes, ma'am.
Great. Yeah, it's
Good
seen.
evening, everybody. Can you hear me clearly?
Yes, please. Yes.
Good evening, everybody. My name is Rasika, and I'll be presenting on conjunctivitis. So, conjunctivitis mainly infective because allergic will be covered by Dr. Shraddha soon. So, it can be viral, bacterial, or chlamydial. And mainly the difference between the bacterial and viral would be the type of discharge. Firstly is watery and viral, and in bacterial you will have a mucopurulent kind of discharge. Coming to the viral conjunctivitis, this accompanies almost 80% of our infection. Most commonly seen, highly contagious, mainly in crowded areas like clinics, schools, and healthcare facilities. It can present in multiple various forms, that is acute follicular conjunctivitis, epidemic keratoconjunctivitis, pharyngoconjunctival fever, and chronic follicular conjunctivitis. So you can see these patients in varied kind of presentations like diffuse congestion. Then you can have a follicular presentation. You can have chemosis and also upper respiratory tract disorder like involvement they'll have. Coming to my presentation, so I took the photo from Sangeeta ma'am because as we know, when we have any infective case, we want to send the patient off as soon as possible. So I had a patient a few weeks back, a 21-year-old female who presented with severe redness, chemosis, photophobia, and watering complaint. And she was already taking treatment for almost 7 to 10 days. And she was given a cocktail of treatment like this. She was on almost 2 to 3 types of antibiotics, Ocupol, Ceflox, and ofloxacin, and even oral antibiotics she was given. This patient had a lot of pseudomembrane kind of picture, a thick membrane she had. Oh, 1 second, sorry. So the patient had thick membrane. So what I did for the patient is I first debrided the membrane because the membrane had become so thick that while it had started eroding her corneal epithelium as well, and she had developed a large epidefect in the superior part of her cornea, and that is when the patient was referred to me. So we debrided the entire pseudomembrane or true membrane because it started bleeding because there was involvement of the conjunctival epithelium as well in her case. And then we started her on a combination of tobramycin and dexamethasone 4 times in a 1 week tapering dose. We started her on a lubricant around 6 to 8 times, or we had advised her 1 hourly, and oral analgesics and anti-inflammatory medications. Mainly for a symptomatic relief, ice compressions were asked, and lid hygiene, that is the separation of linens and everything was advised to her. She came back after 2 weeks. Her epithelial defect had healed, and she was doing well after that. So I would like to ask the panel that when would you consider using steroid in viral presentations, viral conjunctivitis?
Dr. Vinay?
Yeah. So see, the couple of things which come to my mind is, of course, I mean, you've already highlighted there is a tendency to overtreat these patients. Like you saw this patient from wherever he or she was being treated. 3 antibiotics obviously does not really have any real bearing on this.
Yeah.
Second thing is when the fact that patient had either a pseudomembrane or a membrane, which suggests a very significant inflammation which is already existing. And the key here, I think you should highlight, is that photophobia is something which does not otherwise occur in routine conjunctivitis unless there is a corneal involvement.
Right.
In your case, there was an epithelial defect, which is a very advanced version. But
Yeah.
typically, when these patients develop SPKs, which are rough SPKs, they would already have photophobia as an underlying factor.
Yeah.
And I would definitely advocate the use of steroids in these cases.
Yes.
The only thing is that I would keep them under closer follow-up.
Right.
So many a times the problem is that these patients can get super infection. So that is something which we have to keep a track of.
Yes.
Okay. Can I just interrupt?
Sure,
So
ma'am.
she showed us a case where already there was, there was severe conjunctivitis with pseudomembrane. Let's go back to the a patient who has just come to us with early conjunctivitis. Okay, here you are already presenting a case with,
Right.
which you have diagnosed as one. Now, how do you first differentiate only on the kind of discharge, adenoviral or bacterial? Is it only on the ropey discharge or anything else? Dr. Rohit?
Ma'am, mostly it is a clinical diagnosis,
Hmm.
and 90% of the times it is a viral conjunctivitis, watery discharge. In a bacterial conjunctivitis, there will be a lot of copious discharge basically.
Okay, okay.
Yes, and it's
Yes,
very
so,
uncommon to see a bacterial conjunctivitis, or less common
okay.
that way.
So we
All
can say that it is viral until
Proven
you proved
otherwise.
otherwise.
Under
The
Okay,
proven
that
otherwise.
is the
default, yeah,
first
the
thing.
default diagnosis would be viral.
Viral. Now, if it is viral, then do you need antibiotics? And which
Se-
antibiotic?
Ma'am, it is just to prevent any secondary bacterial infections, and somehow most of the times it also acts as a a placebo or something. But definitely a moxifloxacin and one lubricant and one you can start up with an something like a diclofenac with seroscopic imenzin D. What we start, that is to
Now,
relieve
the
the.
issue is like moxifloxacin is also being used for post cataract surgery, and that is the most commonly used antibiotic, like
Antibiotic.
even for say corneal ulcer or something. So would you use, like, say, Ocupol, like in this case, or would you use moxifloxacin, Dr. Ajay and Dr. Vinay?
Yeah, two, three important points apart from the discharge. Always pull the lid down, look for the signs. Usually, you will get follicular reaction. Follicles can
Hmm.
normally you may be seeing follicles in a even otherwise normal eye in the lateral part, but when the follicles are seen in the central conjunctiva and on the nasal side, also on the upper tarsal conjunctiva, and classically you have to see the distribution of congestion. Most of the time it will be away from the cornea. It will start in the fornix and then go on to involve the whole of the conjunctiva. So apart from
Hmm.
symptomatology, clinically, diagnosis also, these 2 points I would highlight.
Very
Secondly,
good,
i do
very
not
good.
go
Hmm.
I do not go directly on fourth generation quinolone. I am quite happy
Hmm.
with the chloramphenicol, and I also give, if you at all you have to give NSAID, ideally it should be avoided. But if at all you have to give, the safest would be flurbiprofen. It is still available, and this combination, you can give it in combination or separate. I prefer to give them separate. I usually do not give combinations. So that is what I would consider. I mean,
So you would
uh,
start only with chloramphenicol and a lubricant, or
yes,
what?
yes, yes. Prophylactic antibiotic. Why do you need a fourth generation antibiotic? You don't need.
That is
And
what,
already,
there are so many
yeah,
different ways.
and
No,
already the resistance to moxifloxacin is rampant.
Resistance is rampant. Absolutely.
Yeah.
Dr.
So
Vinay,
my
what
choice
would
is,
you do? Which antibiotic would you give? Would you give an
so,
antibiotic? If
so
yes, then
yeah.
which one?
So the first thing is, should I give an antibiotic? Now, we also need to understand that other than clinical diagnosis, the other aspect is your peer group, what it is being done in the area whichever you're practicing in. So I do give antibiotics with a clear understanding, and I know that it is not really needed, but I still have to do it because that is what the peer group practice is all around. However, I do not use a fourth generation. Either I use dexorin, that is the chloramphenicol group, or at most I will go for the first generation fluoroquinolones because ciprofloxacin is easily available. And because of non-use, in fact, the resistance to ciprofloxacin now has fallen. As far as using lubricants is concerned, I use it only in two scenarios. If there is some corneal involvement wherein the foreign body sensation is very significant, because there is a small group of thought processes which suggests that actually giving lubricants in these cases is not a good idea because you're actually providing food for the
Actually,
blood.
yeah, yeah.
So
Hmm.
I'm
Hmm.
not a very big fan of using lubricants in conjunctivitis unless corneal
Hmm.
involvement exists.
Okay, now suppose you have started, say, chloramphenicol for this patient, and within a week also it has not resolved. And the patient comes back to you. First, it was only in one eye, now it has come to the other eye. What will you do? Will you change chloramphenicol to moxifloxacin, number one? Will you increase the frequency, number two? At what point of time would you think of adding a steroid? And if yes, then what? Dr. Vinay?
So if the patient comes with a spread to the other eye, that is no reason to change your antibiotic because you also know that it is a viral conjunctivitis. So the antibiotic, either given or not given, has no role in the spread of the infection. It is the lack of hygiene on the patient's part, which is most likely the cause. Having said that, if the patient is continuing beyond a week or 10 days, then I would usually bring in a steroid. And I would probably use a mild steroid to start with, either a fluorometholone or a loteprednol group. And I usually start with 3 times a day or maximum 4 times a day, depending on the amount of inflammation in the conjunctiva.
Okay, now there's some voice coming from background noise. Now, Dr. Rohit, like, would you also follow the same or would you change the antibiotic, number one? And yes, before you start steroids, would you stain the cornea to check if there's anything? If the cornea is clear, obviously, how would you, what is your this thing of when to start? Or from day one, would you give this thing, soft steroid or something?
Ma'am, as a rule, what we advocate the patient or even to our peer groups, at least for a week or 10 days, don't start with the topical steroids. Only
Okay,
only an antibiotic, a lubricant, and some sort of a oral NSAID. And
okay,
topical NSAID should be a strict big no, I would suggest. And topical
yes.
steroids can be started after like 10 days or like once that discharge is less or after 2 weeks. or there could be a specific indications. That could be if I am removing my pseudomembrane, or if there is a presence of a nubular keratitis, or if there is a, for whatever reasons, drop in a vision from 6.6 to 6.9, that this could be either of the indications to start with the topical steroids. And as Dr. Vinay sir was saying, it's like generally a soft steroids like a fluorometholone or something, and 4 times a day should suffice most of the times.
Okay. Dr. Ajay, suppose somebody has started loteprednol from day one only. Suppose somebody has given a combination of, say, moxifloxacin and loteprednol. What would be the downside of doing that, and whether they should do it, whether it's right or whether it's not right, and what is the logic behind it?
Basically, we have to understand the natural history of the disease. We should know how the virus actually, once it affects the eye, how it behaves. So all of us, we
Hmm.
know that for 3-4 days, there will be increase in the inflammation. Whatever you do, next 3-4 days, there will be a sort of a plateau, and then next 3-4 days, it comes down. So the initial week is the time where the virus is replicating very fast. So that is not the time to actually add steroid, because that is going to prolong the course of the disease. So as was rightly pointed out by Dr. Rohit and Dr. Vinay, first week, first 10 days, do not give. If suppose patient
Okay.
already presents with antibiotic and steroid combination, all these patients, I always stain them and look for conjunctival ulcerations. Many times you will be surprised to see conjunctival ulcerations on the uh, bulbar conjunctiva, and you keep on wondering that the initially because of the steroid the conjunctival inflammation comes down, and then usually there will be sectoral fan shaped area, especially in the inferior bulbar conjunctiva, uh, where you can see positive staining on the conjunctiva. This happens when the steroids are started very early in the course of the disease. So it is
Okay.
best avoided in the first week, and you
Okay.
can consider it after 1 week to 10 days if at all required.
Okay. Correct, correct. So this is a very important take-home message to everyone. Like he said, what is the evolution of the disease? So do not give steroids in the first 1 week at least. If it doesn't resolve, then you can think of, right? Dr. Vinay, you want to say something? Yeah.
We must also, just to build up on what Dr. Ajay was saying, is that not every case of conjunctivitis behaves the same way. There are some
Yes.
patients who heal up and within 3 to 5 days they're
They don't need.
absolutely fine.
Yeah. Yeah.
Yes,
And there is that
yes.
other section of people who are bad even at 15 days. So
Right.
either it is not the same virus or it is not the same immunity which the virus is facing. So that is something which must be kept in mind. So that is something which is important as far as explaining to the patient or counseling the patient on day one is concerned. At least in my practice, I now make it a habit. So that
Hmm.
that reduces that patient's doctor shopping and doctor hopping kind of a situation, because you warn them in
Right.
advance that this is one of the varieties which they could be having. And if it doesn't heal in 8 days, it doesn't mean that the medicine was incorrect. It just means that you have the different kind, or your ability to withstand it is different. So
Yeah,
that is
so you
something
tell
which
the
I'll make a
patient,
point.
right? Very good, very good. I think this is so important for us to communicate to the patient, because this doctor shopping happens because at the end of 8 days, if they are still not feeling better, they'll say, and somebody else starts anything else and it start reducing. Then he says, नहीं, उसके पास गए तो कम हो गया, right?
हाथ का जश होता है वो.
Yeah, hi everybody. I've
Hi,
finally.
yeah, Dr. Sangeeta, are you there? Yeah, come. So you can
I
take
reached
over.
the friend's place. Yeah.
Yes, yes.
So I think the discussion so far has been excellent. I think the only one point is, I think Rohit just spoke about it, that for a viral conjunctivitis, always look at the lower fornix, because when you see those follicles, that will make you quite sure it's something else till you get purulent discharge. And one very important thing I always look at is the preauricular lymph node.
Node.
And many
Yeah,
times
yeah.
in an adenoviral or a pharyngoconjunctival, you will find, in fact, sometimes they come with a cellulitis picture. And I've had patients coming with an MRI, some in the ICU, they're referred as orbital cellulitis and they're on IV antibiotics. And you look at the lymph node and you look at the follicles and it's, adenoviral
Yeah,
which has been missed.
yeah.
About the antibiotics, there's one thing which I always avoid are the quinolones, especially the gatifloxacin and moxifloxacin, because in some patients they can develop pseudomembranes, and we know that it is a predilection. So, I missed the bit about the steroids as to when and
Yeah,
which.
what they said was that do not give steroids in the first 1 week to 10 days. and only then start, if at all the patient is not responding, maybe add it to whatever is being added. One question to all of you is, yes, if the patient starts developing that pseudomembrane, why does he develop that pseudomembrane? Is it because the viral load is more? Is it because our treatment is less? Because the patient feels that you are not treating him properly because it has actually increased. And how do you, like you very rightly said, Dr. Vinay, that you tell the patient that it might take 8 to 10 days or it might go in 3 days. It's not that the treatment is wrong, it's just that every patient will behave differently. So, if the patient gets a pseudomembrane, how many percentage of patients get and why? Dr. Vinay?
The pseudomembrane actually is an inflammation or an inflammatory response to the particular infection. So who gets it is a very difficult question to answer. But generally what I feel is where there is a strong immune response, or whether it's like, almost like a too strong a response, that's when you would get it. Or you can get it in patients who have a very high viral load, so the body is not able to handle it. Usually, pseudomembranes will occur within the first week of the problem appearing. It's unlikely that it will come after 15, 20 days. And the whole question of who develops it, I think your guess is as good as mine.
Okay, so there are no specific risk factors or anything, right?
Not
But
that
So
in
I know of.
anybody,
patients,
yeah,
in
anybody
patients,
who
Anybody
reacts
can get.
violently, yeah, anybody who
If
reacts violently to it is just a pointer
Yeah.
towards a increase in the inflammation. It is the degree of the inflammation.
Okay, right.
so in young adults and children, I think at least in my practice, I find it more. I haven't looked at literature, but when you start seeing this shaggy epithelium, always look at the fornices and you'll find that there's a pseudomembrane. And in fact, these are the same patients who are more at a risk of developing an epithelial defect. So sometimes babies are brought in, with conjunctivitis, the whole family is sick, and only the child develops an epithelial defect. So like Dr.
Yeah,
Vinay and Ajay said, that the more violent your immune response, the more severe is the infection. And you also find that out of a family of 4, 5, only one of them will develop adenoviral keratitis, which is recurrent. So that's because it's the
right,
immune response of that individual.
right, right.
Um,
Another thing, Dr. Rasika, you were showing some slides of those subepithelial, many times you have this. Can you show us those, this thing, the second half of your presentation, I think. So all these patients after a few days come back to you with blurred vision or with
Even with
glare and all that. Yeah,
pseudomembranes,
yeah,
these patients, we say pseudomembranes do not bleed, but most of these adenoviral membranes, they tend to bleed because they are there, like sir have said, that aggressive inflammation, and that inflammation tend to invade the
yeah.
conjunctive epithelium as well. So where the epithelium has been involved, it will bleed. So,
Okay. Make it full screen, please.
yeah.
Yeah, thanks.
So these
so
are
these
general presentations.
So these are the individuals who are going to require long-term topical steroids, because it's, especially when the visual axis is involved, we must use steroids and try to give the lowest strength and the lowest frequency that is required to clear the visual axis. You have, like, sometimes a patient might be on these steroids for over a year or longer, and we need to monitor the pressures and, especially keeping
Hmm.
in mind cataractogenesis. So very dilute steroids like 0.1% dexamethasone, which you
Yes.
can dilute further. And something that I do is, I ask them to use a little bit of, say, loteprednol ointment, which they rub on their fingertips and apply to the lower lid margin. So sometimes something as small a dose as this can keep the visual axis clear. So I think the steroids would be the mainstay in adenoviral keratitis while the immune response is going on.
Yeah, Rasika? Yeah.
Yeah.
ma'am,
So once
Can
the
we go back to Rasika? Can you go back to that slide of fluorescent stain? In fact, I wanted to, the blue one, the
The
Yeah,
next
green.
one.
that's
So this in fact is a
no,
stuck-on.
after that.
Yeah,
Yes,
this
this
is
one.
a
Yeah,
classic
yeah.
stuck-on appearance, and I treated this patient for almost 18 months as an adenoviral recurrent keratitis, till I suddenly realized that it's an epithelial microsporidiosis, where we did a keratectomy, put the material on a slide. So that would be one of the differentials. They will also present in the monsoons. They could be unilateral or bilateral, and the lesions look very similar to adenoviral. So, this was the early stages where I didn't know so much about microsporidial, So as against these which are diffuse and subepithelial, if you look at the OCT picture, you'll find that these lesions, when they're inflamed, there will be a haze, and when they're scarred, as against the previous one which was staining positive, they are elevated, stuck on lesions. So that would form a very important differential diagnosis, particularly in the monsoon season for a viral
Yes.
keratitis.
So in
Yeah.
fact, that is very important to keep in mind because there the use of fluoroquinolones is required. So
Yes.
just to make it clear that in viral, we don't like to use higher generations of fluoroquinolones, but in microsporidiosis, if you are looking at that, then usage of fourth generation is actually one of the indications.
Yes.
So how would
Also,
you differentiate, Dr. Vinay, apart from what Dr. Sangeeta said?
No, I think what Sangeeta said more or less
Hmm.
clearly
Hmm.
classifies. See, the point with microsporidiosis is you have to maintain a high degree of suspicion. It's like, as they say, what the brain does not know, the eye does not see. So that is exactly what happens with microsporidiosis, that because classically we are taught that it would occur with exposure to, contaminated water. So we are looking at rural population, but that's no longer
Hmm.
true. Exposure to even contaminated water in the city setups is a very common
Hmm.
parameter for getting these kind of infections. It's pretty common now, is what I would say.
in addition, it's basically the clinical picture of microsporidiosis could be very classical. Subepithelial infiltrates, and the diagnostic would be a corneal scraping. You see abundance of microsporidial spores on your gram stain.
Correct.
Okay, correct.
There's just one last point I wanted to discuss because I've been practicing it recently, especially this year, is the use of topical povidone iodine. And there are articles that describe this as a primary treatment, where in fact there are formulations of topical povidone iodine along with dexamethasone that is prescribed right from day one in the Western literature. I
So,
don't know if anyone has studied this in India, but I have been following this,
ma'am,
that when a patient comes in, we just put a drop of povidone iodine, the same that we use pre-op and post-op on table.
yes.
And if the patient can tolerate it, I tell them to use it at least once or twice a day. And this is believed to cut short the duration and the severity of the infection. Like we've all seen during COVID, just the betadine gargles and the betadine nose drop seem to have helped. So
This is
you
in
have
adenoviral,
Yes.
you're saying, right?
Yes, ma'am.
correct,
So
correct,
I've
correct.
come across a
So
study which has reviewed, this is published just last year, and it has reviewed extensively last 10 to 20 years of adenoviral studies. And recently they have come up with this evidence-based treatment where, like Sangeeta ma'am said, what they do is in adults, in the first visit, they give povidone iodine 5%, just one eye wash, and then they dilute and give the patient, that is 0.1 to 0.5% povidone iodine with 0.1% dexamethasone. And if it is a pediatric case, they give 2.5% povidone iodine and eye wash. If so in the study they have seen that using povidone iodine reduces the symptoms as well as the duration of the disease from 12 to 14 days, which is an average, to just 7 days. And if still it is not been treated by 10 day, if you see pseudomembranes or corneal involvement, then either loteprednol 0.5% or 0.1% dexamethasone is given in 1 weekly tapering doses. And if it is still persistent, then adding a cyclosporin 0.05% and tacrolimus is very, very useful.
Excellent. So, Rasika, would you be able to sum up? Because I think we're running short of time and need to move on to the
Yes.
next case.
Yeah.
So basically, like we have discussed recently, povidone iodine is a very good agent that can be used, and we have it in our practice almost every day. So one drop when the patient is at our clinic can help almost to reduce the viral load by 60 to 70%. That is what the studies have said. Also, like we know that prevention is better than cure. So asking the patient for like good hygiene and disinfecting their hands and minimizing the contact with other people, as well as for us when we see the patient, disinfecting the surfaces and the instruments, and having the patient in our clinics minimal possible time.
Yeah. So, I think we can move on to the second case. Dr. Shraddha, are you
Yes,
ready?
Dr. Shraddha.
Yeah.
You can make it, yeah, full screen, please. Yeah.
Good evening, everyone. Today I'm presenting a case of vernal keratoconjunctivitis, that is spring cataract, which is most commonly seen in this season at the mid of winter and summer. So, I have a case. He is a 12-year-old male child, resident of urban area, and he is complaining of redness, watering, and itching on and off since 2 months. The symptoms are there since the age of 5 to 6 years of age, and there were periods of remission in between as the patient has taken treatment at many centers like ophthalmologist also, and they are taking treatment at homeopathic practitioners also. The redness is present throughout the year, but it was more common in summer season. Past history of multiple consultations. He is giving history of mild allergic allergic rhinitis intermittently, but not on any treatment. So it is not that severe. No history of any using glasses, no history of asthma or eczema, no history of trauma or infection, and no history of any systemic illness. The best corrected visual, uncorrected visual acuity was 6/6 in both eyes. IOP was normal, 13 and 15 millimeter of mercury. Extraocular movements and lids were normal. Conjunctiva, there was moderate congestion with grade 2 to 3 papilla in upper palpebral conjunctiva in both eyes. On cornea, in the right eye, there is a grade 2 pterygium, grade 2 T1 nasal pterygium, and there is a circumferential nebulomacular corneal opacity in the stromal region 1 mm inside the limbus, that is pseudogerontic zone. Actually, I don't have the pic at the active stage of that patient. I will show you the pic when I have treated the patient. On the limbus, there is 360-degree superficial vascularization. These are the severe VKC patients sent by Sangeeta ma'am. You can see the papillary reaction and the ropey discharge with the Horner-Trontat spot at the limbus. Rest of the anterior chamber and the fundus was normal. Keratometry was done. Right eye it was 40.25 and 42.75, and the left eye it was 42.50 and 44 at 86 degrees. Central corneal thickness was 516 and 497 microns. The topography has been advised, but the patient didn't follow up in recent days due to his family emergencies. So the non-pharmacological manage, the first thing is cold compresses. First and foremost is do not rub the eyes. I asked them not to rub the eyes. Cold compresses were advised, avoidance of allergen, and use of protective glasses. Pharmacological treatment, he was started on loteprednolol eye drop 0.5%, 4321 in 10 days of tapering, olopatadine eye drop BID, and cyclosporin eye drop 0.05% BD, along with lubricating eye drop. He was asked to follow up after 2 weeks, and he's now symptomatically much better. These are the pictures after 2 months when the active part of the disease is gone and it is inactive now. You can see this is the right eye. There is a pterygium. It's just 12 years old. It's like it shows it is a chronic inflammatory part of ocular surface. You can see the pseudogerontoxone ring along with the pterygium. And this is the left eye. There is also a pseudogerontoxone ring. So my question to the panel is, how should I proceed with this? He is basically maintaining on cyclosporin and lubricating eye drop now. But since he has a he's at pterygium in the right eye, how to proceed with the management of this patient?
So at this stage, I think this is like a burnt out VKC where, once you get scarring, I think what we need to just see is whether, he has developed any refractive error or keratoconus, or look at the pressure and look at the, cataract, because I don't know how many months you have treated this patient and from acute to this stage, how fast it was, but you would expect this to happen over few years. And I think basically what we need to know is what is basically the cause of this. Is it a genetic predisposition or is it an atopic tendency? Why is it that only some individuals develop this in a family and not the others?
No, ma'am, there is no any family history. He's the only child to his parents. and they are not giving any family history. Like in mother, father also there is no history of any allergic.
But basically, with atopy, this is more common as against a individual who doesn't have an allergic tendency. But what we also need to know is whether it is like throughout the year or is it seasonal, and is this like episodic or does it last all through the year? Because treatment managements will differ on whether it's an hyperacute stage or it's gone into a chronic stage, and which are the drugs. So maybe if Vinay could or Ajay can give the guidelines on how you would start from a mild to a severe form, depending on the classification or the gradation of the allergy, the VKC itself.
I would like to take it.
Dr. Vinay?
Yeah, okay.
Yeah.
So see, essentially, the first thing, as Dr. Sangeeta pointed out, that it is the grade of the disease or the severity of the disease when it presents to you that decides the future course of action. A mild VKC can be treated like any other mild conjunctivitis, mild allergic conjunctivitis. And the other important part is to explain to the patients and their relatives at day one that this is not going to be a one-time treatment and is not going to disappear. You do not have a cure for this disease. It is only a management which is possible. So in the early stages, when there is just a mild presentation, I don't treat them continuously. I just use the drug of choice is olopatadine in these cases. I use that. Now, of late, I have shifted to 0.7% because it becomes once a day, so it's a little easier to manage. And if the patient is in a seasonal episode, then once the episode is over, we sort of withdraw. But I tell them that they need to keep a follow-up. And in case there's a recurrence, then they need to come back. So that's how the mild diseases are managed. And that's generally about 30 to 50% of the patients would be in that category. Our practices get a little biased because the hard to treat cases end up with us. But otherwise, in a general practice, about 60% of the patients or even 70% of the patients can be happily managed in this fashion. Some lubricants, if you so desire.
No
It is-
steroids, you mean? No steroids
I
in
don't
the.
need steroids at this stage. Basically, these patients respond well to either some antihistaminic kind of a approach. And once they settle down, there is no reason to get aggressive.
Okay.
Steroids should be used as sparingly as possible in these patients because most of them who have severe disease or moderate disease are going to need repeat treatments. So we need to keep in mind that there could be a cumulative toxicity which evolves over a period of time. So, and then what happens again is typically these patients keep shifting doctors. So you would end up that everybody in the first round of treatment wants to give them some steroids so that there is a fast relief which is possible. And that is something which is very dangerous from the patient's perspective because the patient ends up being on steroids. So what I usually do in moderate and severe disease, the other thing, okay, which is important is to remember that the disease may not be bilaterally symmetrical. Very, very crucial because you have to raise the upper lid and see the extent of the disease. You will be surprised as to how many times I see that one eye is like literally not affected and the other eye has severe cobblestone disease. Why this happens, I don't have an answer, but it is there. So then in that case, the treatment for the two eyes will be different. You don't have to give everything to the both eyes.
Yeah.
The milder should be treated differently.
Okay.
In mild to moderate to severe diseases, steroids would be required. But again, along with that, start with a immunomodulator like tacrolimus. I prefer tacrolimus because I feel that the routinely available cyclosporin concentration is inadequate for moderate to severe diseases. And therefore, tacrolimus is easier. Otherwise, you have to make 1% or 2% cyclosporin, which is quite irritant to the eye. So that's how I manage. And most of the times, half my time in the consultation is going into counseling the parents because they are much, much more worried than the child.
Okay. Dr. Ajay, what is your choice of steroid and at what point of time would you start the steroid?
I think Dr. Veena has already pointed out when to give steroids. For the milder disease, loteprednol with so many concentrations available now.
How will you define a mild and moderate? What do
Mild
you
and
mean by
moderate now,
mild and what do you mean by moderate?
clinically if the patient is very symptomatic, patient comes to your clinic rubbing both eyes, you see that, And a chronic disease, most of the these kids will have hyperpigmentation around the eye and in the conjunctiva. You put the patient on slit lamp and you see the signs of acute over chronic inflammation. And you just flip the lid. I always put a stain on these surfaces. And in moderate to severe, you'll always see that some areas of the ocular surface will be denuded. So these are the patients where you have to be little aggressive. And my choice now, I have for moderate cases, I am using 1% loteprednol now, which is available, and I find it very efficacy wise quite similar to fluorometholone. The steroid to avoid in these patients is dexamethasone. When it comes to keratogenesis and propensity of increasing the intraocular pressure, DEXA is at the top. So, if at all I have to give, I will give loteprednol, fluorometholone, and in very severe cases, prednisolone acetate, because all of us are cornea surgeon. We have been using prednisolone in our phakic eyes who undergo corneal transplants, and we are pretty happy with prednisolone if at all it is required. Very severe disease. So by and large, loteprednol is okay. If it is moderate, 1% or fluorometholone is your choice. Because what we need is not an acetate derivative of the drug, because it will enter the eye. We want it on the ocular surface. So fluorometholone has an advantage because it is alcohol. It's not an acetate derivative. So that is how I will decide about the molecule which is to be used. And
What is
when
the
it comes,
frequency and how long would you give?
most of the time, 4 times a day is good enough. In very severe cases, you may increase to 6 times a day. And
Okay.
tapering, I usually do it every 5 to 7 days. And you have to basically design it for particular eye. As Dr. Vinay said, that it will not be symmetrical, and every eye will respond differently. So we have to find out the dosage at which the patient can be maintained. And the tapering has to be slow. After once a day, twice a week, once a week, and then take it off. That is very
Okay.
important.
And
And
I think
baseline
it's important.
intraocular pressure, I would like to highlight that because it has very important medical legal implications. Because if you do not check the pressure and the patient develops, unfortunately, steroid-induced glaucoma, then you will
Yeah.
be in a big. So always baseline pressure, and at the end of 4 weeks of treatment, you should always record and make a note that there is no steroid response. That is very
Right.
important.
Right. So do
Basically,
you?
when a
Yeah.
patient has Honortranta spots, one
Yeah.
has to give topical steroids as well as large papillae. Why Honortranta spots? Because if you do not control this with intense steroids, you're going to have a stem cell
In the limb of
deficiency
stem cells.
and
Yeah. Yeah.
eventually an entire knockoff. So, parents will always come saying that, oh, steroid, apan steroid ka deto hai, it's harmful, they'll go for Ayurvedic. You have to explain to them the seriousness of limbal cell deficiency. Maybe even save some pictures on your desktop and say this is what can happen where you can get total opacification. Again, the giant papillae that patients develop, you show them in zone 1, 2, and 3, and the larger ones are the ones that are very bothersome. And also, these are the ones that have predilection for shield ulcer. So, like Dr. Ajay said, always stain and look, you might have a beginning of a shield ulcer. So, I wanted to know how would you diagnose a shield ulcer, differentiate it from a regular corneal ulcer, and what would be the treatment?
Yeah.
And this is always seen in the upper limbus. So unless you lift the upper lid, you're not going to see this at all.
Yeah, that's true. So everting the upper lid is the most important thing. When you stain, you will also see that the staining is not only seen on the cornea but also on the flat top papillae also. So that is the indication, because it is the eosinophilic major basic protein which is released by the eosinophils in the upper tarsal conjunctiva. That is the culprit for breakdown of the corneal epithelium, and this is how the epithelium goes. Then the stroma gets involved, and since there is so much of mucus produced, that mucus gets deposited on the base of the ulcer, and then the epithelium finds it difficult to move over it, and that is why it stays for a longer period of time. And all steel ulcer, and if you are not sure, you have to scrape and rule out infection. That is very important. But most of the time, you will see them either in the upper one third or upper half of the
Yeah.
cornea. You won't
Yeah.
see them in the inferior part. So if you are looking horizontally oval, this position, and if at all times Horizontally oval ulcer can be seen in neurotrophy as well, but then it will have a predilection to involve the inferior part of the cornea, not the superior part of the cornea. So usually I will scrape because the scraping will also help in healing, faster healing of the ulcer. Uh, Here I would like to make a point that every shield ulcer does not require amniotic membrane for its healing. Many times you just stop the mechanical rubbing part. Yeah, even patients, a lot of patients, they heal only with the bandage contact lens also. So you just have to give time for the corneal epithelium to come back, and that is how it heals. So take care of the papillae and avoid the rubbing of the papillae on the corneal epithelium. That is the basic principle.
What would be
Dr.
the role
Rohit,
of cyclosporin and tacrolimus as topical
Uh,
immunosuppressives? Do you
Yeah,
use them?
I am pretty happy with the tacrolimus as compared to cyclosporin, as Dr. Vinay pointed out that 0.05 or 0.09 or 1.1% is not good enough to control the T cell mediated inflammation, and tacrolimus is very effective. I mean, literature says that it is almost 10 times effective than cyclosporin. While we are on these two immunomodulator, I would like to make a point here. Uh, Few of my patients who in themselves were doctors, they read about tacrolimus and cyclosporin, and he said that this is a drug which is used for management of malignancies. I don't want to give my child this drug. So even when I showed them the evidence in the literature that a long-term cyclosporin use is very safe, one of the physician friend, he refused to give cyclosporin. Another physician came up with piece of literature which shows that there is a black box warning with use of uh, tacrolimus, that this can be carcinogenic in future. So we don't still have the answer, but as far as our experience or everybody's experience all across the world is concerned, so far nothing has been reported so far,
No, I
which
think
is
the
like
black box warning has also been taken off, and it's used actually 3% acrolimus is used in a lot of skin problems, especially in eczema. And in fact, a lot of these are first used in dermatology and then are coming into use in ophthalmology. I also wanted the panel's opinion on systemic immunosuppression and the monoclonal antibodies, because these again are used a lot in other atopic and allergic conditions like idiopathic urticaria, adalimumab is used, and I think we don't utilize the full potential of these when it can be sight saving in very severe VKCs. So, what's your
I,
experience or
Dr. Rohit,
opinion on systemic
most
Dr.
of the
Rohit,
time we do not get very severe cases wherein we have to pull in a immunologist or somebody like that who can control the disease by systemic treatment. I don't have any personal experience so far with use of systemic immunosuppression.
No,
Dr.
in
Vinay
fact,
and Dr. Rohit.
I'd like to share a case. There was this young boy who we've been treating for years, me and another colleague of mine, with topical steroids, tacrolimus, cyclosporin, and he also had eczema. And then suddenly it disappeared, and he came a year later. The papillae were gone. There were no Hunter spots, and the patient was absolutely fine. So I asked him, I just asked him, "What is it? Have you been doing anything different?" So they said that, the dermatologist started us on tofacitinib, the eczema disappeared and the eyes also quietened.
Okay.
So that is what actually made me think, like, Sangwan's group has worked a lot on systemic cyclosporin, and that I think you have to monitor very carefully. There is renal toxicity, whereas a small dose of these uh, tofakinase inhibitors can work really well. But again, as ophthalmologists, I don't think we are armed enough with enough knowledge about using these drugs. But like I said, maybe we are underutilizing them in patients where there is a risk of stem cell loss and intractable VKC, which sometimes even with twice a day or thrice a day full dose steroid is not responding. Maybe this can be considered just for 6 months or a year to reduce the severity of the allergy. So, if we increase our medication according to the severity and reduce it, and that's how we need to keep monitoring the disease
yeah.
as well as the treatment.
Dr. Vinay, you want to say something?
There are two things. One is in younger patients, in children, I run into a problem with immunologists and rheumatologists. They are not very keen on starting these drugs when the patient has only VKC as a presentation. Eczema is a different category. So
Yeah.
that is where I face a challenge. The other thing which probably we do a little differently is that we also get these children worked up from the allergy point of view. And there are some, again, see, please understand that nothing is 100% in these patients. So there is a small chunk of patients where taking care of the allergen, which has been identified with these tests, helps these children get better. Again, they may
Right.
still need treatment, but it is less frequent.
Yeah.
I have now a very small cohort, not enough to discuss, but who have been on systemic immunotherapy. That is the other version, the oral one, the oral immunotherapy, not the topokinase inhibitors. These are the ones which are usually used by the immunologists to reduce various other presentations of allergies. So there are some patients who have responded to that. Again, as I said, my numbers are not big enough for me to make a comment, but that is another area which we could look at because again, we don't pay attention to it.
Yeah, coming back to the local treatment, we went from mild to moderate to severe. Now, Dr. Rohit, what is
Yes.
your algorithm like? Dr. Vinay said, he starts with just an olopatadine. If it's moderate, you start with a steroid and you add a tacrolimus to it. So, would you add steroid plus tacrolimus plus olopatadine plus lubricants? What is your, algorithm? How will you keep adding it, and how long will you continue the steroid? How long will you continue the tacrolimus? Can't see him. He got logged out, I think.
Yeah, I think
Ma'am,
so.
I
Dr.
also
Ajay?
want to ask
Dr.
what is
Ajay?
the
Yeah.
percentage of tacrolimus you commonly use in the clinical practice?
Yeah. So your
One-
algorithm as to what is the percentage as well as how long tacrolimus, how long steroids, and would you add olopatadine, tacrolimus as well as steroids? Dr. Ajay?
Yeah, I mean, there is no answer to how long because every disease would run a different course. But Dr. Veena has already pointed out, which is very, very useful clinical decision making, that whenever you have to give steroid, whenever you have to control very severe inflammation, hit it hard. So the basic principle of use of steroid is use the strongest possible steroid with maximally tolerated dosage, control the inflammation as fast as possible, and then when it comes to maintenance, you can shift back. But in mild to moderate severe, you don't really have to use fluoromethalone or prednisolone. In very severe cases, my first drug of choice would be prednisolone. Once it is controlled, then I will come back. And if the disease is running a longer course, if the patient gets attack every change of season, that is 3 to 4 times in a year, so that makes a good case to put them on long-term tacrolimus. Tacrolimus will take almost 3 to 4 weeks for its full action to be seen clinically. Once that is there, and then you keep taking the steroids off. So as I mentioned earlier also, that the taper has to be very, very slow, because if you stop it suddenly again, whenever you have to start back, it is almost 3 times or 4 times, and then you have to repeat the whole cycle. So uh, this is
What percentage
how
of
I would.
tacrolimus?
I
Point
have
0.03
initially,
available.
yeah, point.
point
Huh?
not
Yes,
three is what we use, and the
yes,
dermatologists use 0.1.
one, yeah,
Okay.
but point
So
not
you will
three.
give it for
Point
one
one.
month or 3 months?
Point one, I'm using when I mean ask the patient and the relatives to apply it on the skin, that is on the lid margin and the surrounding skin from outside, because there is transdermal entry of the drug inside the eye. So if you get a point one, you need not put it inside the eye, but 0.03 is very well tolerated when it is put inside the eye.
So the inside the eye ointment you will continue for how long?
You can give it
I
up to
mean,
6 months, 1 year. There's
yeah,
no.
Depending on the
3 months, 6 months,
severity
one
and
year,
the
depending
recurrence.
on, as I said, if the number of attacks are more, then you have to basically continue. And you just have to stop the drug and see if it comes back. You have to repeat the whole cycle. There are no specific guidelines when to how long you have to continue, because every case will be different.
What are the side effects of giving it for around 1 year?
We haven't seen any great side effects with tacrolimus when it is used for a long period of time. And there are some patients who are on tacrolimus for last 1 year or 1.5 years. But
Okay.
most of the times you don't see any great issues with tacrolimus. The only complaint is it stings. That is the only thing. And some patients say
Yes.
that the eye becomes very red the next morning. So these
Yes,
patients
yes.
are very well tolerating the 0.1 preparation which is used on the skin from the outside. So that is equally effective.
Okay. And would you add olopatadine, like I said, along with this and the
So we have
steroid?
to understand that steroid is a global suppression of inflammation, right? It will act at all levels of the cascade. So if you
Hmm.
are giving steroids, you don't really have to give
Need to give
olopatadine.
olopatadine. Hmm.
Only thing is the patient complains of itching, a very severe itching. It does help to add olopatadine, and I am a great fan of sodium chromoglycate, although it is not available very freely.
Not
But
available.
yeah, I do use sodium chromoglycate, especially in children who are less than 3 years of age, because it is recommended that olopatadine should not be used in children less than 3 years of age. So 2 or 4% sodium chromoglycate is a very good option.
And
But
how long can
basically, these are very
olopatadine be continued? How long can
And
olopatadine be continued?
you
What is
can give
your
it continuous.
recommendation?
you
We
don't
give
have to
it.
continue with this. No, because if the patient is free of his symptoms, if there is no itching and the eye is quiet, you don't need the medicine.
No, in seasonal allergy, especially VKC, if you have a seasonal trend, I would start the mast cell stabilizer like the sodium chromoglycate and the olopatadine before the onset. Like suppose they come to me saying that in
Yes,
spring it
preventive.
starts.
Yeah,
So
yeah.
then so it has more a prophylactic use rather than a therapeutic use. And the H2 inhibitors, H1 inhibitors are for symptomatic relief as far as the itching goes. I think one
Yeah.
last question is: are there? Would you advocate any of these, like the supratarsal steroids or papillectomy for symptomatic relief in intractable? Because they develop pseudotosis and also the recurrent shield ulcers. So, would you recommend papillectomy and supratarsal or supratarsal steroid for very severe papillary
Yeah,
conjunctivitis?
I do use suprataxis steroid, but then as I mentioned earlier, I put them on prednisolone for 4 weeks topically. Ensure that the child is not a steroid responder, because if at all the child is a steroid responder, it's a big pain to remove the depot. So once you ensure that the child is not a responder, then you can safely give supratarsal. And there are certain studies which are available which say that any steroid is okay. You can give triamcinolone, hydrocortisone, or dexamethasone. They are equally effective. But we need to have a depot. So my choice is triamcinolone.
Right.
Yeah. One more
So
question,
And here,
Dr.
as we are on this supratarsal, just wanted to highlight that it is not intratarsal. You don't try to push the drug inside the papillae. It is above the superior border of the tarsus.
So Ajay,
So
can you
you have
just
to
describe the procedure for
yeah,
when?
basically you have to double evert the lid, upper lid,
What
and
do you mean
you
by double
see.
eversion? So
I usually use the Desmars and the Q-tip, so that
cute.
works for me.
Correct,
Yeah,
correct,
yeah,
correct. And so you see
and
the upper border of the tarsus, and
conjunctiva.
then
Yeah, yeah,
once that you
yeah.
give it a
You see the loose conjunctiva above the the
yes,
upper border
yes.
of the tarsus. So that is the place where it has to be injected. So most of the time, many colleagues would say that I tried this, but the drug doesn't enter. Everything comes out. So that is the reason why it comes out, because you are not injecting in the right place.
So I think basically the complications of the disease versus the complication of the therapy is what is the fine balance that the physician and the family must work on. And we know that complications like steroid induced glaucoma, cataract, and keratoconus, which is very well known in patients of VKC, can be avoided with proper counseling and proper treatment and monitoring. So you have patients who will just disappear and keep self medicating. So I think we have to spend a lot of time in the consulting, telling the family as well as the patient and educating them about the adverse effects of the disease, the adverse effects of the medication, and how we have to strike a fine balance between the two.
Yeah,
That
I
So,
always
probably is
tell
the
them
most
that.
if
important
we,
point, that you have to spend time on the
yes,
patients, counseling them, because
right,
they are in a very desperate situation at times.
Yeah.
Right.
right.
So I
Now,
think
we
we
So
have
suppose
already.
we also, yeah, no, regarding perennial allergic conjunctivitis, it's how would you treat it differently? And, because it's basically exposure or allergies to house dust mites and things like that. So would it be treated differently? And I think Dr. Jagdeep Kakadia sir they have devised a UV light kind of thing which helps to, remove it disinfects the mattresses and the pillows. And they have found that that works. It's like a disinfectant UV lamp that, um, kills all the mites. So what
So
has been your experience with that,
there
and
are
how
two,
will
three
you treat it
things.
differently?
See, one is if it is perennial, basically they respond quite well to antihistaminic if it is just a perennial allergic conjunctivitis. What I usually do is I try to keep it on an episodic basis. Even if perennial patient is not like 24, 24/7 and 365, they generally have episodes which are more frequent. So I try to treat them when they are episodic and try to withdraw if possible. As far as hypoallergy things are concerned, you have to tell them about hygiene, basically like, frequent washes for the bed sheets and the pillows. There is something which is available that is known as hypoallergenic mattresses and bed covers are available. Some patients benefit with that. The key in some of my patients, especially those who live in smaller houses, is the usage of heavy drapes or carpets. This is something which is, I mean, unusual, but that is something which becomes a problem because they are not cleaned very frequently. And that's where the source of most of these allergies lies. So, how frequent,
Right,
again, it has to be tailored.
So there are
right.
some very common allergens which can be easily avoided in children, soft toys, in adults, just the plants that are in your balcony or in your garden, and pets, we don't think about that, but cat hair allergies, dogs
Yeah.
and birds, and pigeon droppings. These are very, very common, and these are the few things I will ask a patient when they come with chronic allergy or perennial allergy, because these are things we can avoid. Like instead of dusting and using a jhadu, I always say do a wet mop or vacuum clean. And small measures can make a big difference. Even like just wearing a pair of glasses without a number creates a barrier. So I think these are small
Do
remedies.
you tell
Child
the
I, s- I haven't heard of it, but maybe I will look it up. And if that works, it's something really good.
Do we tell
One
the
more.
parents to tell the children to avoid playing in the dust in the school children? So if they have their sports outside, do they stop playing in the dust or in the mud outside?
No, no, no,
What do
no, no,
you?
no need to
Huh,
stop playing because there are
huh.
other modalities where you have these goggles.
Protective
I
glasses.
am Yeah, you have these goggles which can give you a good protection when the children are playing in like outdoors. Another point
Hmm.
which I would highlight is do not miss out on worm infestations in the uh, this age group, especially the children. Many times that is missed, and a regular deworming, because what you need is just regular deworming every 6 months. Sometimes that will control the allergy because you just get the eosinophil count, and you will be surprised that many of these children have undiagnosed worm infestation. So their allergy keeps on going on. So
Hmm.
apart from what Vinay and Sangeeta had already said, I would also look into this. The pets she has already mentioned, and the worm infestation.
No, and as
So
far
there
as
are
What?
playing
studies
is
on the
concerned,
gut.
you have to allow the child to play because otherwise there
Yeah.
are psychological impacts of that.
Yes, yes,
Right,
yes.
And
right.
we talk about the gut biome and the incidence of VKC, which is another
That's
interesting.
a whole topic
Yeah,
by itself.
yeah,
Mhm.
yeah.
Yeah. So I
I
don't
want
know,
to
So,
ask.
Anika, I think we finished our time slot, is it?
Yes.
It's like
Yeah,
yeah.
yeah,
almost.
that's fine. That's fine. Yeah. Shraddha,
Can
you want to
continue.
say
Yeah,
something?
I want to
Yeah, yeah,
ask
yeah.
which antihistaminic is commonly used, like olopatadine versus alcaftidine versus bipostatin,
Yeah.
and what
olopatadine
is
has
the
Disorder.
indication?
shown it has been consistent in managing the symptoms well. We have tried all molecules, but we are quite happy. Another thing is olopatadine. You have once a daily dose, but that works well. Not in our population, or we are pigment addressed, and our allergies are more severe. So you also try giving olopatadine OD twice a day. You will be surprised that you don't need any other medicine there. So don't be hesitant in using olopatadine OD, even if it is written OD, you can use it twice a day.
Okay. Dr. Vinay,
Yeah, I think
anything
I
you would
agree
like
with
to
that.
add?
No, I think we have more or less covered. See, only other thing which I would like to again probably use this platform as is if the patient has a severe VKC, then maybe it is a good idea to refer to somebody who is doing more work in ocular surface and cornea, because these patients are chronic patients. They need variable tailoring of their treatment. So which, if you are, as a general ophthalmologist, if you are comfortable doing it, absolutely go ahead. But if there is any hesitation in your mind, then I think you should make it a point to refer to a colleague who is doing these kind of things, because these patients, otherwise, the problem with these patients is they don't get attention in the general OPD, and they end up with these cataracts and glaucomatous changes, which is an unforgivable problem, because then there's nothing you can do for the glaucoma.
Another thing is many of these go for second, third, fourth opinions because this keeps recurring. So we need to be very understanding and support each other when a patient comes to you from somebody else. So it's very easy. The patient is always like saying that doctor didn't give the right treatment. That is why it has come back again. So we have to. Yeah, please, because this is so important. All of us will be seeing second opinions of somebody else. So what we say at that time is very important.
See, I tell them that the particular doctor who has treated you has seen what the condition was at that point in time, and according to that, whatever was the best, that is what has been done for you. Whether I'm going to continue the same or different depends on what I'm seeing today. So you don't get into this whole me superior kind of a situation, because obviously me superior today will become somebody else superior tomorrow.
Right. So let's all be very supportive of each other. Wherever the patient goes, we should all, be united.
Absolutely.
So,
And
so I think
also,
that was a great,
the family will come, the parents will say, "Kai आयुष्यभर थेंबच घालायचे का?" And what I tell is, putting a drop that much of a bother for you. Suppose your child was on insulin, would you tire from giving him that insulin jab? So I suggest for you to put a drop in the child's eye so as to make him comfortable, even if it means months or years. You should not shirk your responsibility.
Yeah, and usually they outgrow it after some years. It usually reduces. So maybe that reassurance that yes, this is only for a few years now. Slowly that will reduce. We cannot say exactly when, but yes, at least they'll
What I
probably
have
keep
clinically
in the
seen
hope
is,
of that.
clinically seen is somewhere around 21 to 23. They settle down without medicine. Yeah, so I always tell them की तुम्ही रोज जेवण करता तर मग काय प्रॉब्लेम आहे का, तर मग रोज ड्रॉप टाकायला काय इश्यू आहे. So you just link that with their daily activity and then just take the seriousness out of it. That's it.
त्यालाच का झालं? What is your answer to that? यालाच कशाला आहे? बाकी लोकांना नाहीये, बाकी मुलांना नाहीये.
So I tell them like एखाद्याच मुलाला दमा होतो की नाही, सगळ्यांना घरात दमा होत नसतो, तसंच आहे. I always liken the ocular allergy to bronchial asthma. So I said there is going to be flare up. Sometimes may need hospitalization. Sometimes it's just a tablet. Sometimes it's a spray. Sometimes it's nebulization. So depending on the severity, you have to adjust the treatment, and that makes them understand the situation better. So Anaga, I wanted to see if I can share my introduction slides, because I think
yeah, this is like Sangeeta, this is like routine conferences. The inauguration is not done at the start of the conference. So inauguration is at the day 2. I fail to understand it.
थोड़ा सा हटके है, but now I don't know how I will be able to share, because this is again I've gone into a jinx. So I go to the bottom and I say share.
It's okay.
क्या? अरे तुम ही दिख रहे हो, कुछ भी हुआ तो भी I'm seeing only you.
If it's a presentation, no, so it started screen sharing. It started screen sharing.
Yeah, but then now I don't know where my presentation is. It's showing me only all of you. Okay,
no,
1 second.
You'll have to open your presentation and minimize it, and then.
Has it come?
Yeah.
Yes. Wow.
But are you seeing me also? No.
Yes.
You can start the presentation. You can start the presentation. Yes.
Just make it full screen. It will be there.
I'm seeing myself as join the presentation. So
no, that's okay.
No, we can see it now. Yes.
Yeah. So this is Vinay, who is one of the senior most.
sound.
There's some issue with the
Yeah.
sound.
So I did some jinx.
Now it's okay.
No,
Yeah,
but
now the sound is fine, but
I don't know
Okay,
what
so
happened.
very fine.
I think I just got to leave the meeting.
It's very funky, Dr. Sangeeta.
I think I have to give up.
it's okay, ma'am.
Okay then. Now
Oh,
can you
yes.
see me? Okay, so this is Vinay when he's not. So he's an entrepreneur. I call him. He's manufactured this Biocore ages ago along with the NCL. And when he's not making something, he's eating my brains about write this, write that, prepare this, prepare that. Can you hear me?
Yes, yes, yes.
And then this is Ajay, who finished his cornea fellowship in '98, and he's been faculty at LVPI for 3 years, and then he started his own practice. He's very fond of teaching, and he's a consultant with NKP Sims and Lata Mangeshkar, and he's also a writer and a poet and an avid cyclist. And there we have Rohit Bang, who did his cornea fellowship from Shankar Nethralaya, and he worked as a consultant at Ganpati Nethralaya.
Madam, sorry to interrupt. We are using multiple devices, madam. 2 devices.
And
There is an echo, Dr. Sangeeta.
Sorry?
There is an echo. I just want to check if you are using 2 devices.
I don't know what's happened. I think I just have to leave. And here's Rasika, who is also an artist, and Shraddha, who is also a singer and spends time with her child. Thank you.
There is a lot of echo. Yeah. I think now it's fine.
That's done.
Yeah. Thank you. Thank you so much. I think we have all had a great discussion both on conjunctivitis as well as on VKC. On behalf of Team MOS, I'd like to thank you, Dr. Sangeeta, for being such a great moderator. All our 3 panelists, Dr. Vinay, Dr. Ajay, and Dr. Rohit, for such wonderful discussion, and Dr. Rasika and Dr. Shraddha for your case presentation.
Thank
It
you,
was
ma'am.
really nice, and I hope we have had a good take-home message to be given. We would like one PDF from all of you so that we can share it with our MOS members for a clear take-home message. Right?
I think some credit
Thank
is
you.
due to you also for thinking up of such an idea, because this is something different from the thing. So definitely it shows that
Thank
you're
you.
applying your mind for the betterment of MOS.
Thank you. Thank you so much. Thank you so much.
Hello. Thank you.
Uh,
Sorry
Thank
about
you.
Okay.
Bye
Bye.
bye.
Thank you
Okay.
so much, everyone. Thank you,
Thank you.
Sai and Numerotech, for the
Thank you,
smooth. Yeah, thank you. Yeah, bye.
Yeah, thank you.
Thank you.